My name is Elliot Hout, and I'm here with the rest of the Johns Hopkins VTE Collaborative. We are a group of physicians, nurses, pharmacists, and researchers who are working on prevention of venous thromboembolism. We have a jam-packed section for you today, and each one of us is going to be talking about different parts. We're going to take questions at the end. We've got about 45 minutes worth of slides, and then please send in your questions via chat or on Twitter. So without further ado, I'm going to move ahead and tell you what we're going to talk about, which is basic epidemiology and public reporting about VTE, and then we're going to touch on systems approaches, the impact of missed doses, the role of nurses, and patient engagement. So to get us started is Peggy Krause. Peggy is a pharmacist who works with our group.
Thank you. So like Elliot said, I'm the pharmacist, so I'm going to just go over a few things to start off before we get into the nitty-gritty of our research. So most of you are probably aware VTE stands for venous thromboembolism, which essentially composes of a DVT, or deep vein thrombosis, and a PE, or pulmonary embolism. Although if you have a patient with the more rare occurrences, such as the splenic vein or hepatic vein, those would count as a VTE as well. So we have been talking about VTE since the 1800s. As you can see, Rudolf Virchow started discussing clots way back when, and there has been this triad that's been developed. So any one of these three things occur, then the patient is at risk for having a clot, whether it be stasis, injuries to the vessel wall, such as in trauma, or if somebody's born with a hypercoagulable state or develops a hypercoagulable state, they can be at risk for developing a VTE. So why are we worried about VTE? In 2008, the Surgeon General put out a call to action to prevent DVT and PE. As many as 350,000 up to 600,000 or maybe more in the U.S. alone will suffer from a VTE each and every year. We also know that VTE is deadly. We have over 100,000 deaths per year from PEs, and this is more than breast cancer, motor vehicle accidents, and AIDS combined. Now, one thing that we are trying to do here is help raise awareness, because most of you probably are aware of breast cancer. There's a boatload of organizations that are helping raise awareness. The same thing with AIDS and motor vehicle accidents, but yet you don't hear a lot about preventing blood clots and how deadly they can be. Hang on. Okay. There we go. So we had our first DVT symposium way back in 2009. It doesn't seem like it was that long ago, but it was. And we actually were lucky enough to get the Surgeon General to be one of our keynote speakers right after they had put out the call to action. Most of you are probably aware that there's a plethora of risk factors for blood clots, ranging anywhere from the older you get to trauma, just being in the hospital, being pregnant, infection, recent strokes, and such. So we also know that there's a cost associated with VTE. There's been a few studies that show each DVT can cost, depending on which study, from around $12,000 up to $16,000 per patient per event. And as you know, most likely some patients will have more than one blood clot. If we look at the long-term effects from developing a blood clot, such as venous stasis and ulcers that can occur, we're looking at a cost of around $250 million each year. We know that VTE is preventable most of the time. However, we know that not all events are preventable, even despite getting the absolute best prophylaxis that is out there. There have been at least 8 randomized controlled clinical trials done in the orthopedic population between total knee replacements and total hip replacements that show they still develop VTE symptomatic, not just those that are found on scans, up to 2.5% of the time. So when CMS came out with a ruling that they were going to make VTE a never event after total knee and hip arthroplasty, Dr. Hout and Dr. Stripe put together this commentary saying that this is an impossible measure to meet because we cannot prevent all events of these types of surgery. You also will see the plethora of guidelines out there, anywhere from the APCP, College of American Chest Physicians, which put out their guidelines, trauma with the East Association, Ortho's got their own guidelines, OBGYN, and the American College of Physicians. Now, despite having all these guidelines, raising awareness, we still have an underutilization of DVT prophylaxis in our patients. In this study from 2004 from Dr. Goldhaber and Dr. Tapson, they showed that only 42% of their patients were getting prophylaxis prior to their development of a VTE. Here's an international study, because the previous study was only in the U.S., that showed pretty much the same thing. In 32 countries, we still have an underutilization of VTE prophylaxis. While surgery tends to do a little bit better job than the medicine population, it's still well underutilized. So this has led to a call to help raise awareness, because there's clearly a disconnect between the evidence out there and the execution that can prevent DVT to the point where it's really become a public health crisis. Dr. Goldhaber had this quote with the American Public Health Association in 2003. So AHRQ also has put out statements that DVT and PE is the most common cause of preventable hospital death. So just a side note, so if you can put us on mute, because I know somebody's having a coughing attack like I was afraid I might do. So if you could put us on mute, that would be terrific. Thanks a lot. We also know that DVT is one of the ways we can really improve patient safety, and should be one of our #1 strategies. Also, AHRQ has put that prophylaxis for VTE should be one of your top 10 when it comes to improving patient safety practices within your institution. Again, to kind of promote our little group, Dr. Hout and Brandon Lau also wrote the chapter for AHRQ regarding the prevention of VTE, a brief update review, which is well worth your time reading. So now Dr. Hout is going to take over and talk about surveillance bias and public reporting of VTE.
Hi, so people ask me how I got interested in DVT, and I think you're going to understand after the next couple minutes. There's a lot of conflict out there about screening high-risk asymptomatic patients for DVT. This is mostly in the trauma literature, but in other groups as well. And the idea behind it is that if you screen high-risk patients, you are going to find events and treat them before they become a fatal pulmonary embolism. However, there's another side of the coin, which is that there is a con. It may be very expensive, not cost-effective, and you might also end up anticoagulating patients who might not need it, and there can be harm from that anticoagulation. So if you go to the guidelines on the topic, there's actually conflicting guidelines from EAST, which is one of the trauma organizations, and the American College of Chest Physicians. EAST suggests that this, at least in trauma patients, this may be cost-effective and decrease the incidence of PE. However, the American College of Chest Physicians suggests that this should not be performed. So now we've got different organizations that are giving different opinions. And what that did was it made us wonder, should we be screening patients or not? So we got a call from the state telling us that our trauma center had the highest DVT rate in the state. And we said, well, maybe that's just because we're screening more patients, we're getting lots more ultrasounds. So we did this small study at our center. We did a before and after study and found that after we implemented a protocol to screen a lot of trauma patients, we did 4 times as many ultrasounds and got 10 times as many DVTs identified. We then went ahead and looked at this on a national level using the National Trauma Data Bank. And this paper was entitled, The More We Look, the More We Find. If you break trauma centers into 4 different groups by the number of ultrasounds they do per patient, the group that does the most ultrasounds has a 7-fold higher DVT rate than the other 3 groups of hospitals. The more you look, the more you find, at least in trauma patients. People said, well, maybe that's an issue of different patient populations. So we actually did a patient-level analysis controlling for all these patient-level variables that are known to affect DVT, and found that if you're a patient at a center that does a lot of ultrasounds, you are twice as likely to have a DVT identified. I'm not going to say you're twice as likely to get a DVT, but you're twice as likely to have it identified and put into a registry. And then when you ask trauma surgeons what's their opinion is about 3/4 of us think that we should be screening high-risk asymptomatic patients. The other quarter are really not sure or disagree with that statement. So there's variation in practice. And this is a classic example of surveillance bias. The more you look, the more you find. And those providers who do more testing may appear to provide worse care, even though it's really just a testing phenomenon. So what are the implications of that? The implications are that variability in screening leads to variability in DVT rates that are reported, and those rates are biased. And you can't just look at the outcome rate of DVT alone. It's probably not the best outcome measure. So sometimes we've talked about this before. We all feel like Dilbert when the boss tells us that we'll just use the test results anyway because it's the only data we have. None of us were very happy with that answer, and we hopefully came up with a better idea. And that better idea is this definition of preventable harm. So we suggested that the performance measures could link the process of care with the adverse outcome. So this preventable harm is a VTE in patients who got no prophylaxis or suboptimal prophylaxis. So we spoke, we gave that suggestion, and CMS actually listened. And if you keep up with the literature, that's the new VTE number 6. So VTE number 6 is the incidence of potentially preventable VTE. And when you look at that definition, it's patients who are diagnosed with confirmed VTE who did not receive VTE prophylaxis while in the hospital. That's the idea behind that measure. So the papers I just mentioned before were all on trauma patients, and this difference of opinion is mostly in trauma. So then the question becomes, does this occur in other patient populations as well? So this is a paper in JAMA from a few years ago now about surgical patients. This looked at 11 types of surgical patients, wide-ranging types of surgery, cardiac, vascular, cancer surgery, orthopedic surgery, et cetera. Almost 1 million Medicare patients. And if you look at the main graphic from this paper, it shows the exact same thing. The more imaging you do looking for VTE, the more events you find, whether it's VTE or DVT or PE separately. The more you look, the more you find. This is not just a phenomenon in trauma. It happens in surgical patients as well. And this is one graph from one project. We had a Masters of Public Health student did his thesis project. Basically, if you look at hospitals and look at the relationship between their process measure, SCIP VTE2, that's the process where they're giving appropriate prophylaxis, versus the outcome, which is PSI-12, there's really no relationship. It's a really, really flat line, and everybody, or most of the people are clustered, the hospitals are clustered way at the end near 100%. Most hospitals are doing very, very well, and there's no relationship between the process and the outcome. And if you actually compare the hospitals that reported being 100% perfect for VTE prophylaxis versus the lowest end hospitals in the bottom fifth, basically the same exact outcome rates. So it just goes to show that this specific measure that was used as the initial measure of the process is really not a good measure. It doesn't really correlate with the outcomes and doesn't really help you. So the jury is still out. We're still not sure what we should be doing and what we should be reporting related to VTE as far as public reporting. Is it a process? Is it an outcome? Is it the combination? And you should know that VTE1, the prophylaxis measure, is now being retired. So that is no longer going to be a reportable measure because it really was not all that helpful. So I'm going to turn this over right now to Mike Stripe, who's going to talk to us about can a systems approach improve VTE prevention and VTE outcomes.
Thank you very much, Elliot. So I'm Mike Stripe, hematologist at Hopkins that's been working with our group for the last, I guess, 8, 9, 10 years. So can you take a systems approach to improving VTE prophylaxis? And we did look at this starting back in 2005, but it's important to know that while education, which was part of our approach, is not enough, that you really have to use multiple different active strategies as shown in this systematic review, including reminding clinicians and providing them assistance in risk stratification and selection of risk-appropriate prophylaxis to have the biggest impact. And in this paper from BMJ from now a few years ago, we kind of go through the history of how we used what Peter Pronovost, the TRIP model, which is translating research into practice. We used that same model that he applied in surgical site infections and applied that to VTE, and as you see, we've had some success with that approach. So initially in 2005, when we were starting this process, we did not have electronic order sets yet. We were still using paper order sets, and so this is a version of one of our paper order sets that shows at the top we had risk factors, then below had then the risk categories, in the middle had then different risk-appropriate prophylaxis selections, and then had contraindications at the bottom of the sheet. And while this helps organize clinicians' thinking and approach to DVT prophylaxis, it was suboptimal in that we couldn't ensure that it was in every chart at the time of admission or transfer. It made it very difficult to get data out of the system as to see how we were doing. And so once we started a transition to an electronic order entry system, we got together and redesigned our approach using computer order entry. We made a mandatory risk assessment tool that would lead the clinician into risk-appropriate prophylaxis using a few questions to risk stratify patients' VTE risk and their bleeding risk, and then gave them advanced computerized clinical decision support to help them give them selections that would be appropriate for their patient based on their risk. And this is a screenshot of one of those DVT order sets that you see at the top. It has patient information about weight, also gives them a calculated creatinine clearance if in case they're going to use a low molecular weight heparin, and then has several questions that look at major and minor risk factors as well as risk factors for bleeding. And then when they've answered those questions, then it gives them the recommended prophylaxis options that would lead to optimal prophylaxis for their patient. And so what we found with the benefits of this approach, well, one, instead of the paper order sets where they weren't always in the charts, this put VTE prevention in the workflow, that it was part of the order sets for admission and transfer. It helped the clinicians do this rapidly, so it took a few seconds and guided them to risk-appropriate prophylaxis, and it allowed us also to make any literature advances that occurred in the literature, we could try to translate these into changes in the order sets. And it made it much more effective for performance monitoring and reporting, which was very difficult with our paper order sets. The keys to our success, as it was reported in this paper, was that we had a multidisciplinary team from the start. We had interested physicians, nurses, pharmacists that worked on the front lines. We had medical informatics professionals that helped us design and build the system and then extract the data out of the system so that we had seamless reporting. We also were fortunate to have leadership buy-in. We collaborated with all the service teams, the different specialties, to make sure that the order sets we designed would fit with their practice, but were yet evidence-based, and educated the providers on the evidence basis in their area. And then the computer system allowed us to not only measure baseline performance, but also conduct ongoing performance assessments so that we can track how we were doing. So did it improve our prophylaxis and our outcomes? Well, we did 2 studies that suggest it did. That this is the first study published in 2012 looking at our trauma service, And it was a single center study, obviously, a pre-post study. We had 1 year of data before the order set went into effect, and then 3 years of post-order set data. And what we found, on the next slide, you see that there's a dramatic increase in prophylaxis compliance, went from 62% to almost 85%. During this time period, you also see a concomitant decrease in all thrombotic events, and more importantly, you see a significant decrease in preventable harm, so that patients were getting prophylaxis, and thus we're doing all that we possibly could to prevent thrombotic events. And so preventable harm went from about 1% of the population to 0.17% of the population, dramatic change. We also saw the same thing in the Department of Medicine, where we had an order set guiding prophylaxis selection in that group of patients. Again, it was a pre-post study, about 1,000 patients before the order set introduction, and then almost 1,000 in the post period. What we saw was significant increases in optimal prophylaxis that was appropriate for the patient's risk level. In addition, we saw dramatic reductions in the number of patients that got no prophylaxis, from 24% to 4%. And then on this table, you can see that when we followed patients out to about 90 days, there was a significant reduction in total VTE from about 2.5% to less than 1%. And more importantly, preventable harm, as you see highlighted in this red box, went from 1.1% of patients to no patients in the post-implementation period had preventable events of thromboembolism. And so when, in 2010, the North American Thrombosis Forum sponsored a competition of different approaches and strategies to decrease venous thromboembolism, we submitted our intervention, and we're fortunate to receive one of their DVT Care Awards for our work. And it's also been recently highlighted by AHRQ in their guide to effective quality improvement as one of the hospitals they selected as providing a model for how you could prevent a hospital-acquired venous thromboembolism. And so now I'm going to turn the program over to Brandon Lau, who is our medical informatician, to talk about other strategies to improve VT prophylaxis administration with performance feedback.
Thank you very much. My name is Brandon Lau. I'm a clinical informatician by training, and I've been working with the VTE Collaborative for some time, trying to figure out how we can empower clinicians and nurses and patients with data to help improve VTE prevention practices, and that's what I'm going to be talking to you about now. What we saw in the last couple of slides is that after implementation of clinical decision support, about 85 to 90% of patients are now being prescribed risk-appropriate prophylaxis. So that's down to the individual patient level. If patients are getting what is appropriate for their level of risk. And what that tells me is that somewhere between 10 and 15% of patients aren't being prescribed risk-appropriate prophylaxis. And because we've been able to move forward with this decision support tool to collect data electronically, we thought that it might present an opportunity to really harness the power of analytics and electronic information and bring performance data right to the frontline providers to try to incentivize performance improvement. And our first thought with this was to give feedback to attending physicians, which you'll see highlighted in the dark blue lines here. But to the eye, correctly, there isn't really much of a difference between attending physicians on the proportion of patients who are prescribed appropriate prophylaxis. The primary reason for this is that attending physicians rarely, if ever, write VT prophylaxis orders. Instead, what you can see in the light blue lines are the proportion of residents who write appropriate prophylaxis orders for the proportion of their patients. And you see wide varying differences. A lot of residents do the right thing all the time. Some residents do the right thing none of the time. And a smattering of residents do the right thing some of the time. And because they're quasi-randomly paired with attendings, it doesn't really seem as though there's any difference between attendings on risk-appropriate prophylaxis prescription. So we thought that residents would be the ideal target to give individualized feedback about prescribing habits. And that's what we did. We started by giving the previous 3 months of data, which you'll see in the first figure, and you'll see a lot of red in this. And think about who it is that we're talking about here. Very, very competitive residents, surgical residents, wanting to be the best, driving to be the best, and we rank ordered them to tell one of them that they are in last place. And that fact alone drove performance on a month-by-month basis, where we went from the mid-80s of patients being prescribed appropriate prophylaxis to the high 90s. And this is a highly sustainable intervention of using electronically available data to give performance feedback. Here we see 15 months before giving feedback and 15 months after, a dramatic improvement with only one drop-off when our new interns began. But even with that drop, performance very rapidly returned to the high levels that we saw before the new interns arrived, overcoming this July effect and providing meaningful feedback to frontline prescribers about their habits. But this actually brings up the other question. Are we actually targeting the right thing at this point? I mean, as I had mentioned, 85, 90%, now high 90% of patients are being prescribed appropriate prophylaxis, but is that where we should really be targeting? And the classic assumption here is that when patients are prescribed medications in hospitals, they will always be administered. But is that actually a fact? And when you think about optimal VT prophylaxis, optimal VT prevention, it really requires risk assessment of patients, prescribing the appropriate medication, for nurses to administer the medication as prescribed, and perhaps most importantly, for patients to accept that medication as it's prescribed. A lot of work goes into these various steps, making sure each one is done. And what we found from a small study published by colleagues of us looking at high-risk trauma and general surgery patients is that missing even a single dose matters. Missing doses of VT prophylaxis is associated with developing VTE, and certainly among patients who do develop DVT, about a quarter of patients missed one or more of their doses, as opposed to 5% of patients who missed none of their doses. So we can tell that, that missing doses matters. In addition, we found very, very similar findings here, that about half of patients who developed hospital-acquired VTE received appropriate care. They were prescribed the right medication, and they received every dose of medication as prescribed. The other half were divided nicely into two groups, about a quarter of whom simply were not prescribed appropriate prophylaxis. There was an opportunity to improve on the prescribing side, but 3/4 missed one or more of their doses. They were prescribed the best practice prophylaxis, but they missed one or more of their doses, representing an ideal opportunity to improve. So we did a small study looking at a little more than 100,000 doses of all prophylaxis at Hopkins Hospital, and we found that 12% of doses, 12% of all doses are not administered, with the greatest documented reason for non-administration as patient refusal. About 60% of all doses missed due to patient refusal, which might indicate that there's a problem across the hospital uniformly. But when we look at the individual floor levels, we see that some floors, about 5% of doses aren't administered, and in the extreme outliers, we see that somewhere between 25 and 30% of doses aren't administered. And there was a lot that we could gain from understanding just the distribution based on the data, but it's really when you take it to the floor and talk to nurses and talk to patients to find out what's really driving this. And so for that, I'm going to turn it over to one of our lead nurses, Deb Hobson, to talk about what we found from the frontline nurses.
Thanks, Brandon. So hi, everyone. I'm Deb Hobson. I'm the nurse who's been on this project with Dr. Strife from the beginning. So how he says is 8, 9, or 10 years, however long we've been doing this. And like Brandon just said, you know, even working from the beginning, we put a lot of focus on making sure the patients got the appropriate prophylaxis. And I felt really good as a nurse that we were moving in the right direction. But then you see this data here that Brandon just showed you, and I was shocked by the amount of missed doses and how it was really different on all of our floors. So we really wanted to find out what was happening out there on our nursing units. And so, whoops, what did I have to use that one, sorry. So this is what we did. We started looking, you know, on the nursing units and wanted to do some research out there. And I worked with a pharmacist, Stacy Elder, and we did some quantitative and qualitative observations of what was going on. And I'm going to show you those. And one of the papers we wrote, and that's there, and it is with Stacy Elder, it's Hidden Barriers to Delivery of Pharmacological Venous Thromboembolism Prophylaxis. And we did. We went out there. We did a survey with nurses. We did observations where the pharmacists truly observed the nurses and their interaction with the patient when they were giving the prophylaxis dosage. And then after we did those, we met with different groups of nurses to find out more. We had focus group meetings. So, and this is sort of what we found out from the quantitative survey. We had one of the questions, I have the clinical knowledge and experience to determine if it is necessary to administer the VTE prophylaxis injections to patients. And this was good. I mean, they felt like they did have the knowledge, but it was 87% medicine and 79% surgery, which I think is important that nurses have the knowledge, but not that it's necessary to administer because that's a prescribed dose. And then also the second one, nurses use their clinical decision-making skills to determine when to omit unnecessary doses of prescribed VTE prophylaxis injections for each individual patient. This, as a nurse, and the doctors in the room and everybody will tell you, when I found out this, I was shocked as a nurse that we were making decisions on whether or not a routine prescribed medication for a patient should be given or not. It's not a PRN medication. So I was really shocked and I wanted to know more of what was going on. So is VTE prophylaxis optional? And these were some of the comments when we had the focus group meeting. One nurse would say, I push harder for my patients to accept heparin if they have like sickle cell disease as opposed to say pneumonia or something where they're just here for IV antibiotics. I was like, And then another one, sometimes if it is the middle of the night and they're due for their heparin and the patient's asleep, I'm not going to wake them up if I don't really feel they need that VTE prophylaxis. And one of our favorite ones is the ambulation myth. We make the clinical decision all the time as to whether a patient needs VTE prophylaxis every day based on how much the patient is ambulating. And then another one, and we observe this, hey, Mrs. R, it's time for your heparin dose, but as long as I see you out in the hallway high-fiving me, we can hold off for now. Now, really? So we looked at that, and we knew that there's not enough on ambulation to tell us for sure how much a patient should be doing or not. There's not enough literature out there. So we really, at that point, knew that we not only needed nursing education, but again, to go along with what Brandon showed you, most of those missed doses were patient refusal. So we also needed that we wanted to focus on the patient side. So that's when our team together looked at the grant and we got the grant from the Patient-Centered Outcomes Research Institute, and that's when we started this project, the PCORI project. And it was a 3-year project, which we're ending in July of this year. But you can see our project is titled Preventing Venous Thromboembolism, Empowering Patients and Enabling Patient-Centered Care via Health Information Technology. And with that, the objectives are to really help the patient so that they can make informed decisions. And we wanted to focus on that patient-nurse communication, along with empowering the patient so that they can take an active role in their preventive care for VTE. And then also, one of the biggest parts to this, and Doreen, our nurse researcher on the project, will go over this, but really get the patients engaged. And we wanted to talk to them as soon as possible after they missed a dose, when they did that patient refusal of that VTE prophylaxis. So we decided to get a lot of major players involved, a lot of the national organizations and key stakeholders, and those are listed here. You can see we had ClotCare, North American Thrombosis Forum, the National Blood Clot Alliance. We even involved our own Patient and Family Advisory Council so that we could really get input on them on what they wanted so that we knew how to approach this big problem of patient refusal. And then here's the website, and you can go to the PORI website at any time, and it's Research in Action, and you can find everything that we're doing. And with that, I'll turn it over to Doreen.
Hi, this is Doreen. I'm a nurse educator for the Department of Surgery, and have been working with the collaborative for about 2.5 to 3 years now. And I'm going to be talking about how nursing education can improve VTE prophylaxis administration. As Brandon had talked about and Deb had talked about, we're looking at impacting all aspects of the VTE prophylaxis process. So when you're looking at education and delivering education models, what we really seem to evaluate for the most part historically is we're looking more at the affective and the cognitive domain. So we look at the reaction of the learner to an education model. Did they like it? Did they learn? And we measure that by surveys usually. But truly is liking it and learning the education actually translated into a change in behavior? And in relationship to VTE prophylaxis, do we stop missed doses? And then ultimately, are we able to impact VTE events? So we partnered with Central Nursing Education to build an educational program to impact all of these aspects. We looked at learner-centric and interactive scenario-based dynamic education module and delivered it to a set group of nurses, bedside nurses at this institution. It was a learner-based, scenario-based platform. We actually looked at patient safety events that had been reported and developed the scenarios based on that. We used critical thinking and worked in multidisciplinary venues to get the information across. The platform itself was fairly generic. It was a storyboard. You know, one of the negatives with this is that some of the avatars were a little more Laura Croft as opposed to our natural patients population that we have. But really engaging the user in going through these scenarios. And if the user was getting the information correctly, they weren't penalized. They were able to move throughout the scenario. But if the user had wrong answers to any of these scenarios, then they were remediated at that time. So where is this going to go? Does this work? Does in those domains that Kirkpatrick measures, are we going to change behavior? Is this effect going to be sustained? Is there a honeymoon phase that's associated with this? Do we need an injection of education? And how is that going to look like? Are we going to be rolling this out to more nurses, just our whole hospital or the health system? Are we able to deliver this to other hospitals? At this point in time, we're sharing these modules with the Illinois Surgical Quality Improvement Collaborative. So seeing how this impacts, again, those last two levels in the Kirkpatrick model will show whether we're actually able to impact behavior and ultimately decrease VTE events. So what do patients really want? When you're developing the patient education, so we've already talked about physicians and providers, risk assessment. We've talked about the education that we need from the nurses to impact the administration of the VTE prophylaxis. And now we're looking at what patients really want that are going to impact that refusal. And how did we do that? We used a modified Delphi method. We surveyed patients and family members, the end users. We recruited them using social media, so websites, Facebook, Twitter, and we got more than 400 respondents from all of the international organizations and our internal organizations that Deb had actually discussed. What do patients want? We asked. What are patients willing to read? What is the venue? Who is to deliver the information? How long is that information supposed to be? And what does it actually look like? When we got that information, we not only took the information and built the educational delivery methods, but we also reviewed those face-to-face. We had focus groups. We went out into the community and reviewed this. So we weren't the ones that were developing the information and the education and the delivery system. The patients were. So what did the patient education bundle look like? What did the patient specifically want? Well, they wanted paper. Interestingly enough, in this day and age, with all of our different, again, social media, videos, and access to a lot of online gaming, patients really wanted a paper form. So we utilized a template that was built on some adult learning theory, but the information that was in that paper was written literally by the patient. Interestingly enough, we would ask when we were wordsmithing things, what was the comfort level of different terminology? Patients liked information such as shots and belly. Now, when we would review this again with providers, the providers would like to change that to injections and injections or abdomen. But when the patient spoke, we listened. We actually used what the patients had wanted. You need to make it easy to find. An information paper is only as good as the ability to hand it to a patient. When you're developing this type of education, make sure that it's easily searchable. We used keywords that were common terminology and also had it so that when you entered those keywords, this patient education form would be at the top of the list when you did your search. We made it in multiple languages in a large font. Again, the information is only as good as the patient's ability to understand it. Truly patient-centered. If you have a patient who speaks English or understands English, and that's wonderful, but doesn't it really show the value that you have for the patient itself and truly patient-centered care if you are able to hand that patient an educational information packet that's in their language? I had an elderly gentleman who was Russian, and the look on his face when I handed him our patient education packet in Russian was priceless. He was engaged. This was a patient that was going to have a discussion, and we would be able to talk about what it meant to help keep him safe from clots. So with the video, what did patients want? They wanted a 10-minute or less video. They wanted physicians, nurses, and patients talking. They wanted to see someone who looked like them, who was talking about the fact that they had a clot or what they did to help prevent a clot. We had an Oscar-winning director, and we took all of that information that the patients gave it, put it into this video, and then we screened it for our Patient Family Advisory Council. More importantly, we made those changes based on the feedback that we got. These are some of the patients that we had. We had physicians, patients. We filmed them in their own homes. We showed them what tests they wanted. Again, all information that we received from the patients and what they wanted and how they wanted to learn. So what did our intervention actually look like? We had a real-time alert of any non-administered dose. This alert came to a pager or an email. You don't need to go and talk to patients necessarily that are taking the medication. You need to target the patients that are refusing. If patients that are taking it want to speak to someone, you're able to do that. But you want to do a real-time one-on-one discussion with the patients that are refusing. Once the page would come in, the nurse educator would go and then it was a bundled approach. And again, patient-centered care, so what the patient wanted. Did they want the paper? Did they want to watch the video? Did they want to discuss with a nurse? Did they want none of this? This intervention usually went one of three ways. You would have the discussion, educate the patient, and then the patient would take their prescribed VTE prophylaxis. Sometimes we'd have patients that wouldn't necessarily want the shot. They understood the importance, but the shot was not necessarily something that for whatever reason they were able to deal with at that time. And at that time, again, using that patient intervention or patient-centered intervention, we would work with them to get the best, maybe not the best evidence prophylaxis, but the right prophylaxis for that patient. And then other times we would have patients that truly would refuse. This was an informed refusal. This was an educated refusal, and again, patient-centered care. This project was rolled out from April 2015 through December 2015, and at this point in time, we're looking at the effects of this. Where do we go from here? We're looking at getting the word out. How do we get patients, as you can see, the amount of patients that we have aren't aware of how important VTE prophylaxis is. So getting the word out nationally, internationally. We need to look at sustainability. How are we going to maintain the progress that we're able to achieve?
So all in all, I think we've covered quite a bit today. We've touched a little bit on many, many different aspects of VTE prophylaxis. You got a feel for our whole entire team who had a chance to present. And we do have some acknowledgments. This is our group at a couple of different pictures along the way. And it's important to notice that, you know, we've invited many important speakers nationally and internationally to our VTE symposium. On the bottom, somewhere in that bottom left-hand picture, you see Bill Gertz in there. Richard White is over on the bottom right. It's important to see patients. So if you look in the top left part at the four people sitting at that table, those are patients who present. Every year we have a patient panel at our VTE symposium where patients get up and tell their own personal stories of what did it feel like, what did it happen when I had my DVT or my PE. So you can get a feel for a patient perspective. And as we're talking about engaging with the community, that's some of us in a little more casual attire, attending a NBCA, National Blood Clot Alliance, walk to help support a community engagement. It's some of our group with some of the members of the NBCA locally. And then these are our emails, and a few of us are active on Twitter and happy to answer questions along the way there. All these slides and eventually the audio will be put up on the Armstrong website. And then the final slide I'm going to leave up while we do our question and answer session is some other resources. So just as a reminder, we heard a lot about the paper forms that were created, the education. Those are out there for free. You can go to the Armstrong Institute website and download the version. You can download it in English. You can download it in English in the large font version, and a series of translated into other languages to use with your patients. The patient education video that already got mentioned, you can go there to watch it. You can see what the video looks like. You can watch it to learn yourself, and you can show it to patients. There's also a link to our PCORI Research and Action website, which really is talking about the active project we have going on, and an article from last summer in the Wall Street Journal that focused on the group and what we're doing here, and really trying to highlight and improve public awareness of how important blood clots are. So with that, I think we're going to end the presentation side. I know there are lots and lots of different questions that have come in via chat that we're going to try to answer. Peggy's been following them along on her computer, and I think what we'll do is Peggy will be triaging them, asking them to the group, and then the other, or the six of us will all get together and try to answer the question depending on our personal expertise.
Okay, so I know some are chomping at the bit here, but the first question I said I would save to the end is, what VTE risk scoring tool do you use, and is it for all patients, surgical, medical, et cetera?
Yeah, so this is Mike Strife. So these order sets we designed back in 2007, 2008. So at that time period, there was no evidence-based risk stratification model. So we, at that time, I think in conjunct, in association, what you'd see in the CHEST guidelines at that time was that every patient that came into the hospital was assumed at risk. I think this is particularly more important for the medical patients than the surgical patients, but every patient was at risk. And so our risk stratification model was basically based on the Mednox study. High-risk patients got high-risk prophylaxis with enoxaparin or TID heparin. Lower-risk patients got BID heparin, and patients that had contraindications to pharmacologic prophylaxis got sequential compression devices. And in our medicine population, about 20% of them get SCDs as their prophylaxis because they have contraindications. Now we're making a migration to EPIC, where on the medicine side, because there's a realization there are low-risk patients in the medicine patient population, that we're going to use in our EPIC order sets that are going to be launched on July 1st. On the medicine side, we'll be using the improved risk score that Alex Paropoulos and group identified, and that was, I think we figured it was the most evidence-based risk score for medical patients, so we're going to be using that. And then on the surgical side, I guess I'll turn it over we don't use the same risk stratification for medicine, surgery, trauma. In all our original order sets, they were all based on the literature at the time in those different specialties. Elliot, I don't know if you...
And I would say that on surgery, we use kind of a modified bucket approach. Our patients in surgery are either very high risk, or moderate risk. We don't find anybody who's really admitted to the hospital who's low risk. It's very hard in this day and age to find a surgical patient who is at low risk who's admitted to the hospital. All those patients are going home. So I would tell you that there's many different risk scores that are out there. There's the Caprini score, the Rogers score. There's all these different approaches that can be done, the Padua score in medicine, et cetera. There's no data that I've seen that any one is better than another. I think the most critical part is that you use something. So you standardize it so that everybody gets some sort of risk assessment, whether it's a point scoring or a bucket or whatever, so that you're really considering it for every patient and then giving that patient the appropriate prophylaxis based on their risk stratification.
And I guess there was one question I think I saw over Peggy's shoulder, that there was just a concern about bleeding complications. Have we monitored those pre and post? And bleeding complications, major bleeding was extraordinarily uncommon, at least in the medical population. It was about 1 in 1,000 patients had a major bleed in our pre and our post order set experience. So I think major bleeding is very uncommon in our patients, and that's because we ask the providers to risk stratify their patients. If they're a high bleeding risk patient, we're not using pharmacologic prophylaxis in that patient. Oh, sorry.
No, go ahead. I was just going to say, ambulation is been part of many questions here, and mobility versus DVT prophylaxis, especially in medical patients, because some people will not give, if they can get up and walk around, they typically don't give them DVT prophylaxis. So that's multiple questions that.
And I think
anybody want to address?
So I think that, this is Brandon, I think that there hasn't really been some strong evidence that would actually show what the association is between ambulation and VT prevention, particularly in a hospitalized patient population. And one of the frequent questions that I ask the interns who come to Hopkins Hospital when giving their orientation lecture is, what is the amount of ambulation that equals a standard 5,000 unit shot of heparin? And I hear everything from a nebulous 2 laps around the unit to 3 miles. And I think that really underscores the fact that we don't really know what the contribution of ambulation is to VT prevention. In reality, it probably does something. I just don't think that anyone really has the evidence to really say that it works every time and this is how much.
There's many different randomized trials for the pharmacologic medications. there's very little data on ambulation. And as Brandon points out, we don't know the dose, we don't know the frequency, we don't know any of that. So I think when people put together evidence-based approaches to VTE prophylaxis, I don't know that you can have any very strong evidence that ambulation alone or in combination with anything else works. It's certainly good patient care, and there's lots of huge pushes at our hospital and others for ambulation and getting patients out of bed and physical therapy, et cetera, but the data that prevents VTE is really pretty sparse.
Well, and if anything, I think, you know, Mike and Elliot, you can talk to this too. We're even finding, especially in surgery, that patients going home after surgery because of our NSQIP database, that they're even developing VTEs within 30 days. So now we're even looking at prophylaxis at discharge and how long do we need to do that too. So I think, you know, we know that mobility in the hospital and immediately after discharge is not the same mobility that patients were doing prior to being hospitalized.
Right, and this issue of post-discharge prophylaxis is a really important question. There have been a few studies on medicine patients, and, you know, the data are conflicting, and some show that the prophylaxis actually leads to more bleeding and doesn't really necessarily help with events. There are some specific surgical patient populations where the data is relatively strong. Certainly on some orthopedics, especially joint replacement procedures, hip fracture, as well as some abdominal pelvic cancer surgery, the extended prophylaxis does have a relatively strong data.
So, it looks like there's a question here about obstetrics patients and our preferred screening tool. So there's no evidence-based screening tool in obstetrics. So when we put the order sets together with the obstetrical physicians, the OB department, that as you indicated in your question about an older patient with or an obese patient with a C-section, that those are risk factors, certainly obesity, age, C-section puts it at higher risk. So patients that had surgical deliveries tend to get pharmacologic prophylaxis while they're in the hospital. We're not sending any OB patients home with prophylaxis. But so there's a variety of risk factors in the OB population, medical disorders and such, and those patients will get prophylaxis. Most of them don't get prophylaxis in the hospital. It's only the high-risk patients that get surgical deliveries and have serious medical problems or previous thrombotic events that are getting prophylaxis.
What about weight and BMI?
So,
Dosing.
Yeah, I mean, so as far as weight and prophylaxis, I mean, our bariatric surgery group uses, increased doses of enoxaparin for prophylaxis in those patients. So instead of 40 once a day, they're using 40 twice a day in people that have BMIs over 40. And I think in BMIs over 50, they're using 60 twice a day based on the bariatric surgery literature. We're not doing that in medicine, although there's certainly studies looking at the medical population and showing that higher doses in very large patients are probably appropriate in medical patients too, but they're not randomized studies. These are retrospective observational studies.
And we did a systematic review through AHRQ a few years ago that really looked to answer this question in the obese patients. And really, except in bariatric surgery, there's a paucity of data on what we should be doing. Lots of different people at lots of different institutions are doing it differently, double dosing their enoxaparin or increasing their heparin amount per day, but there's really not strong evidence on what should be done.
So there's also been, how much longer do we want to go here, guys? Okay. So there's a question about not much discussion about sequential compression devices or other mechanical prophylaxis. Doreen, you want to?
Well, do you want to give the...
I mean, I guess in medicine, we're using it in about 20% of patients that are contraindicated to pharmacologic prophylaxis. In surgery, they use a lot of combined prophylaxis. We don't do that in medicine. They're either pharmacologic or mechanical prophylaxis, but in your high-risk surgery patients, they'll use both. We use
pharmacologic and we use sequential compression devices up until discharge. So we even have, motivated and engaged the family members to help the nursing staff out. All of our patient rooms now have SCD pumps available in them, and so the patient gets connected to the sequential compression devices as soon as they're done ambulating or in the bed. Whether it's the bed or the chair, we hook them back up, and like I said, we've even started engaging family members to help with that.
And then TEDS, I mean, what?
Yeah, well, we found out a study a couple of years ago, we found out that we were using both TEDS and SCDs, and this tells my age in a way of nursing, because years ago what we found out when we first started using sequential compression devices, patients were complaining because it was sticking to their legs. It was the old type of devices that were they had a lot of plastic on them, and patients thought they were hot and sticking to their legs. So at that time, we started using both TEDS and SCDs, the TEDS making the SCDs more comfortable. And then recently, we found out, especially in our surgical ICUs, that patients were measured appropriately for SCDs prior to going into surgery, but then they were fluid overloaded in surgery, and when they were out in our ICUs, we were seeing pressure ulcers from the TEDS. So now our standard is pretty much SCDs for all our patients. If TEDS are needed or if they're requested, we can still get them, but we now use SCDs in our operating room and all of our surgical units without the TEDS.
And it looks like there's a question, I was just looking over Peg's shoulder about neurosurgery, and what we do with neurosurgery. And so neurosurgery, the approach working with the neurosurgeons here is we use, they prefer unfractionated heparin to low molecular weight heparin, and so although there are data with low molecular weight heparin, we use unfractionated heparin. There are obviously no preoperative dosing of anticoagulants. They use SCDs during the case, and until the patient's ambulatory, they use starting 24 hours after the surgery. If hemostasis is achieved, they'll start unfractionated heparin prophylaxis. So that's what the neurosurgery group does here.
There's another question that I want to try to reply to. This one here says, it sounds like we prophylax 96% of patients, and that's much higher than the ACCB guidelines recommend because there's going to be many low-risk patients. And I think what we need to do is clarify that 96% is we gave the appropriate prophylaxis to the patient based on the clinical decision support tool recommendation. Right. And it might be that the clinical decision support tool recommendation suggests, heparin twice a day, and we ordered heparin twice a day, that counts. It might be that it suggests that the patient is contraindicated so they get mechanical only, and as long as we give mechanical only, that's the appropriate order for that specific patient. So it's not that we gave prophylaxis and ordered, for example, low molecular weight heparins in 96% of our patients. We were following the recommendation of the decision support tool 96% of the time, which is a key difference. And we do agree there's going to be patients, whether you believe the low-risk patients who shouldn't be getting anything, whether they exist or not, that's still up for debate, but there certainly are patients who are contraindicated for reasons, and we should not be giving them prophylaxis because it's going to weigh the risk and benefit then goes in the wrong direction.
And it looks like there's another question here about hip fracture patients and delays in surgery. What chemoprophylaxis is recommended? And generally, on the orthopedic service, for many years, low molecular weight heparin was the prophylaxis of choice. That has changed some, I would say, in the last few years as aspirin has become more acceptable, although our group, I think, prefers an anticoagulant approach. So we would recommend low molecular weight heparin prophylaxis until the surgery is performed. If you're going to do surgery and you've given a prophylaxis preoperatively, you would start your surgery 12 hours after your last dose of prophylactic low molecular weight heparin, and then restart it 12 hours after the surgery if hemostasis is appropriate. Nowadays, I think they're using a lot more aspirin in low-risk patients and low molecular weight heparin in higher-risk patients is the approach of the orthopedic surgeons here. And that's reflected in our new order sets, not our current order sets, but the ones that will be active in July.
There's one question here about the pediatric population.
We had actually more than one question about the pediatric.
Oh, I think I'm only seeing some of them, I apologize. But there's at least one question about the pediatric population, and at least the general answer to that is the data on that is not nearly as good as the adult population. There's tons of studies in the adult populations. There are many fewer. I don't personally know of any randomized trials in the pediatric population. Some have extrapolated down to the younger kind of teenage group, the post-puberty patients. We've looked at this in trauma, and patients in trauma seem to match up with the adults around the age of somewhere between 13 and 16. They reach adult risk, and we treat them like adults. But the data in there is a lot more sparse. So what we've done is we do have a risk assessment tool for pediatrics that was put together with our pediatricians and our pediatric hematologists, based on a little more expert opinion rather than the pure evidence, and it really guides people to the most highest risk patients, the older patients, the ones with thrombophilia, et cetera, to consider prophylaxis in that patient population.
So just to add to that, because I did respond to one of the questions with regards, we have a pediatric anticoagulation management service, which is also looking at a point scoring system for risk assessing the pediatric population, and there is still looking at how well this is performing.
Yeah, I think Neil Goldenberg and Cliff Takamoto, who are the pediatric hematologists at Hopkins and at St. Pete Hopkins, St. Pete Children's, are developed. They've collected evidence in the pediatric service and are putting together a risk score for pediatric patients, and they're using that, the first version of that, in their order sets currently.
Does not need mechanical.
And so looks like there's a question in SCDs as far as the concern that it's only the only data are in stroke and surgery patients, and I think that does point out a limitation in the SCD data, that it's almost all surgical data, or from the recent clot trials, stroke patients. But I guess we have extrapolated from the stroke patient population to the medicine patient population. We've kind of considered them as a high-risk medicine patient, and then there's lots of data in the surgery literature that it's effective. And so we're constrained by the data, but have felt that is persuasive enough that should be what we should use in patients that are contraindicated to receiving prophylaxis, and have been persuaded that the TED stocking, since, as Deb shared, we've had the similar experience to the CLOTS trial, that TED stockings cause skin breakdown in patients, and so I've de-emphasized TED stockings as a method of prophylaxis in our patients.
So thanks so much, everyone, for joining our webinar today. We really enjoyed the discussion. We'll be sending out the slides, as we mentioned, by March 15th, and you have our contact information, so please feel free to reach out to us. Thanks again for joining us.
Thanks for joining.
Yeah, thanks.
Thanks, everybody.